So Matt, maybe we can start with you in terms of relapse disease. What are the things that you use to trigger treatment for relapse patients, and what factors are you evaluating at the time of treatment for relapse disease?
Sure, so I think a very important consideration is that we sometimes can see early signs of relapse, and this does not necessitate restarting therapy for CLL. We still use the same IWCLL criteria that we use at initial diagnosis to wait, and some patients can be observed sometimes for long periods of time, months or even years after they've shown signs of progression. But once patients do meet IWCLL criteria for treatment again, then there's a number of different considerations. Of course, the usual ones we talked about already in the frontline setting, age and comorbidities and so forth. And of course, as we've discussed, the FISH status can change. So we can't assume that patients who are 13q prior to their initial therapy still have that marker. So we always need to recheck the FISH test in that situation. As I mentioned before, IGHV is a stable test, so we don't typically need to repeat that. And the other thing that's important, I think, in terms of determining what the next therapy is how long did they respond to the prior therapy. Some patients do get very durable response from chemoimmunotherapy, but then relapse 5 or 6 years later. And that is a population where we could consider potentially re-challenging them with chemoimmunotherapy. But I think if we're going to do that, we have to counsel patients that the likelihood of a durable response a second time to chemoimmunotherapy is relatively low. There's increased risks of myelosuppression and significant infections, and probably an increased risk of myeloid malignancies. So I think that in general, for most patients, we would move to a novel agent-based approach in the relapsed refractory setting.
So there's 2 large randomized phase 3 trials that are being presented at ASH this year. Maybe we can start with Steve, and you can comment on the DUO study, which is a randomized trial looking at a novel new PI3 kinase inhibitor, and maybe review that kinase inhibitor for us and what the results were from the DUO study that was presented here.
So the DUO study uses duvelisib. And duvelisib is a combined delta gamma inhibitor. So it was one of the early PI3 kinase delta inhibitors, sort of following behind idelalisib. And my read of it is that it's very similar to idelalisib. In other words, very active drug, as idelalisib is, but I think very similar toxicities in terms of the potential for colitis or diarrhea. I think in their study, I believe they sort of mandated certain anti-infectious prophylaxis like pneumocystis, and so that would explain why perhaps they don't see that as came out of the idelalisib experience. Remember, the other place we saw very significant idelalisib toxicity was in the upfront young patients from Matt's institution, and those, of course, aren't the subject of the DUO trial. So it's a nice randomized trial. It'll probably lead to approval of the drug on that basis, but I think you have to really respect the toxicity of this agent to decide where and when you want to use it. So.
Matt, you've worked on PI3 kinase inhibitors. Your group has. Maybe you can comment on idelalisib is a delta inhibitor. There are other inhibitors. Maybe you can comment on the potential difference between the gamma delta versus delta isoform inhibitors.
Sure. Yeah, so there are actually 4 isoforms of PI3 kinase: alpha, beta, gamma, and delta. And there's now a range of different inhibitors. Of course, in solid tumors, folks may be familiar with some of the pan PI3 kinase inhibitors that have been explored there. But in CLL, we started by looking at delta-specific inhibitors like idelalisib, which subsequently got approved. More recently, actually, there's been an alpha-delta inhibitor that's been approved, copanlisib, in indolent non-Hodgkin lymphomas. Hasn't been explored as widely in CLL. It's also an interesting agent. There's duvelisib, which we just discussed. And I think another exciting agent is a drug that was just recently named umbralisib, formerly TGR-1202. And at this ASH meeting, I'm presenting a poster on the safety of this drug across different studies in 350 patients. And I would say, based on that data set, that this drug does seem to have a differentiated safety profile compared to the other PI3 kinase inhibitors. We are seeing fewer of the immune-mediated toxicities like transaminitis and colitis. And there's a reasonable number of patients now out past 1 year on treatment, so I think that that's a really strong signal. So I think that that's the type of drug that's being explored also in randomized phase 3 trials now, and if those also look promising, that could also be headed toward an approval.